Hello, good evening, friends. I am Dr. Lalkrishna, final year surgery resident, and today we'll be discussing an important topic, that is thyroid gland and its disorder. So, we are having a session after a long time, and I was busy with my exams, so sorry for the delay. So, now we'll again get back to the topics in surgery, which will be very helpful for NEET PG especially, and apart from that it will be very useful for MBBS students, also other medical specialities. So without further delay, let's get started. So thyroid disease. So if we see that thyroid gland is normally impalpable, so we cannot palpate or see normal thyroid gland because it is impalpable and not visible as a separate organ, as we can see some of the organs in the body. Like we can clearly see the thyroid cartilage or the Adam's apple, but we cannot see the thyroid gland. So if this thyroid gland gets enlarged in a generalized manner, that is generalized enlargement, then we call it as goiter. So if it is generalized enlargement of thyroid gland, it is called goiter, and this term came from Latin gutter, that means throat. So the goiter is a swelling in the neck region, the throat region, and it is the generalized enlargement of the thyroid gland. We will see these in more detail. Next, coming to if there is a single swelling in this thyroid region or the lower neck region, that is the discrete swelling or a nodule in one lobe of thyroid gland, and rest of the gland is not palpable. So the rest of the gland is normal and there is no abnormality in the other part. So then it is called a isolated or a solitary swelling or a solitary nodule. Isolated or a solitary nodule. Then if this discrete swelling or a discrete nodule has associated abnormality in the other part of the thyroid gland, that means there is enlargement of other part of thyroid also, but one nodule is very prominent, then that is called a dominant swelling or a dominant nodule. So these are some of the very important terminologies which we have to understand before we go ahead, and then we can understand the topic better. Further, we can classify these thyroid swellings into as simple goiter, or these have euthyroid state, which we'll see in detail. So before going ahead, the thyroid swelling can have three states. Either the patient can be euthyroid, that means the patient is having no symptoms of thyroid abnormality, that is the functional symptoms due to thyroid hormones, or the patient can be hypothyroid where the thyroid hormones are less, or hyperthyroid where the thyroid hormones are more. So it can have any of the feature. We'll see them in detail, but at present we'll see the topic, that is the classification of thyroid swelling. So it is called as simple goiter or simple thyroid swelling when the patient is in euthyroid state. If there is diffuse, that is complete generalized enlargement of thyroid gland, that is due to diffuse and hyperplastic, diffuse, hyperplastic, diffuse and hyperplastic swelling, then it can be due to three causes. Generally it is physiological, or in the puberty or in pregnancy. So here there is diffuse hyperplastic enlargement of thyroid gland, and generally it can sometimes be regress spontaneously. So it can become normal spontaneously. Other is multinodular goiter, where there are multiple nodules in the enlarged thyroid gland. We'll see this also in detail. Then comes the toxic goiter. So what happens in toxic swelling, toxic thyroid swelling? Toxic is a synonym for hyperthyroid features. So the patient will be having hyperthyroid features along with a thyroid swelling. So what are the various types? So these can be diffuse, that is also known as Graves' disease. So there will be diffuse enlargement of the thyroid gland, plus there will be hyperthyroidism features. Then there will be multinodularity along with hyperthyroidism, or a single swelling, that is toxic adenoma. Then comes neoplastic swelling. These could be benign or these could be malignant. These can present as a thyroid swelling, or also they can present as multinodular goiter. Then these swellings can be inflammatory in origin. So when these are inflammatory, they can be divided into various classification like autoimmune, and in autoimmune there is chronic lymphocytic thyroiditis or Hashimoto's disease. These are the autoimmune variants. Then in granulomatous disease, we have de Quervain's thyroiditis. In fibrosing disease, we have Riddle's thyroiditis. Infective could be bacterial, viral, or tubercular syphilitic in chronic. And lastly, we have others, that is amyloid. So it could be any of these, and they can together have hypo or hyperthyroidism features. Now in these swellings, how do we evaluate them? Definitely we'll go for history and examination initially, which we'll see in another class someday. And now we'll be seeing the investigations which we do for thyroid disorders. So first and foremost is the basic one, which is the most commonly utilized, is the thyroid function test. In thyroid function test, we check for the thyroid hormones, that is T3 and T4. Along with that, the hormone that controls T3 and T4, that is TSH, that is thyroid stimulating hormone, which is released by the pituitary gland. And sometimes, if required, we go for anti-thyroid antibody, which are antibodies which act against or in competition with TSH, or sometimes TSH on the TSH receptors or other receptors. So this is the first investigation which is done, and this test is done after overnight fast. So the patient should be NPO after night, after at least 10-12 in the night, and after that in the morning we go for this thyroid function test. And among these, the TSH is the most sensitive marker. So TSH is the most sensitive marker and is the most important aspect in the thyroid function test. So if that is decreased, then what do we see? That the TSH is decreased in the body, and it indicates hyperthyroidism, since it follows the negative feedback loop, negative feedback physiological principle. So when the TSH is decreased, that means that the body has high amount of thyroid hormones. So when the body is having high amount of thyroid hormones, this situation will be hyperthyroidism. I hope people are getting it. So I'll just discuss this in Hindi, that will be simplifying for all of us. So as the body, जैसे हमारी body negative feedback loop साइकिल से चलती है फिजियोलॉजी के अकॉर्डिंग। तो जब TSH कम है, इसका मतलब है कि TSH पे नेगेटिव फीडबैक एक्ट किया हुआ है, किसके थ्रू? तो उसके हार्मोन्स के थ्रू। TSH क्या करता है? T3 T4 को बढ़ाता है। तो अगर T3 T4 बढ़े हुए हैं तो वो नेगेटिव इम्पैक्ट, नेगेटिव फीडबैक देगा TSH को, पिट्यूटरी को, और TSH कम हो जाएगा। तो अगर TSH कम है, इसका मतलब शरीर में हाइपरथायराइडिज्म है। और इसका उल्टा, इफ TSH इज इंक्रीज इट इंडिकेट्स हाइपोथायराइडिज्म। मतलब TSH तो बढ़ते जा रहा है लेकिन T3 T4 बन नहीं पा रहे हैं, या फिर निकल नहीं पा रहे हैं, या काम नहीं कर पा रहे हैं, है ना। तो इस वजह से TSH बढ़ते जा रहा है और थायराइड हार्मोन्स कम है और पेशेंट को हाइपोथायराइडिज्म वाले फीचर्स हैं। ये हो गया थायराइड फंक्शन टेस्ट के बारे में, जो कि फर्स्ट बेसिक पैरामीटर है। देन कम्स ultrasound of neck. So this is the second investigation which is commonly done and is the imaging investigation of choice for thyroid disorders, which is commonly used. So how does it help? It helps in differentiating the swelling, whether they are benign or malignant, and how we have to treat them. It helps in defining how we have to treat them. Then how do we differentiate benign and malignant nodules or swellings of thyroid? So we have various parameters which we'll see in detail. So one is echogenicity, which is a feature of ultrasound. Echogenicity. So if the color is less than the normal tissue, then it is called hypoechoic. It is called hypoechoic. What is it called? Hypoechoic. And this is a feature of malignancy. This is a feature of malignancy. So hypoechoic, when the swelling has less color or less visualization, or it is lighter than the normal echogenic tissue, then it is called hypoechoic and it is a malignant feature. Whereas in benign, it will be either isoechoic, that is similar, or hyperechoic, that means it will be brighter or whiter. Then coming to calcification, if there are micro calcification, बहुत छोटे छोटे calcification है, then again it is a malignant feature. Then border, if they are irregular, then it is a malignant feature. In regular border, it will be benign features. Then margins, if there is infiltrative margins or invasive margins, यानी घुस रहा है margin में, then it is again a malignant feature. Non-infiltrative margin will be benign feature. Then increased intranodular vascularity. So vascularity, if the nodule has more vascularity inside, then it is a feature of malignancy. यानी नोड्यूल के अंदर वैस्कुलरिटी बढ़ जाता है तो वो एक मैलिग्नेंसी का फीचर है। तो इन सारे पॉइंट्स को, इंक्लूडिंग ऑल दीज पॉइंट्स, when we analyze, we have a reporting system, that is TIRADS, which is Thyroid Imaging and Reporting and Data System, which is very important to categorize the swelling into whether it is going towards benign features or malignant features. So whatever we have discussed, we'll see this in more detail regarding the ultrasound features of the thyroid. So first of all, we have seen echogenicity. So if it is anechoic or hyper or hypoechoic, then it is 0 and 1 point. So it is less points, and hypo and very hypo are more points. Then comes the shape. So the shape of the nodule, if it is wider than taller, then it is 0 point. If it is taller than wider, then it is 3 points. Then as you have seen, the margins, if they are smooth, then it is 0 point. If it is ill defined, then it is 0 point. If it is irregular or lobulated or is having extra thyroidal extension, यानी thyroid के बाहर जा रहा है, then these last two, lobulated or irregular or extra thyroidal extension, these will be having 2 and 3 points. Then seeing the composition, if the composition is cystic or spongiform, then it is 0 points. In case of mixed cystic and solid or solid, it is having 1 and 2 points. Lastly, the echogenic foci, so it will be related to calcification. If there is none or large comet tail artifact, then 0 point. Macrocalcification will be having 1 point. Peripheral rim calcification will be having 2 point, and punctate echogenic foci, that is microcalcification, will be having 3 point. So all these points when we add, all these points, then we come to a score, that is the Thyroid score. And in this, the composition, that is the first one, composition, the echogenicity, the shape and margin, we choose only 1 point from this. Whereas in case of the last echogenic foci, we can choose as many as applicable. So the maximum number of score that can occur is 17 and the minimum will be 0. So if the score is 0, then it is called Thyroids 1. So the score is 0, then it is called Thyroids 1, and this will be benign. These lesions are benign and we don't need to go for a other test or FNAC, which we will see in detail in some time. Then if it is having 2 points, if it is having 2 points, then it is again not suspicious, so we can call it as benign. So we don't need an FNA, or we can follow up. If they are having 3 points, then it is mildly suspicious or mild chance of malignancy. So now we see the size of the swelling. So if the size is more than 2.5 centimeter, so the size is more than 2.5 centimeter, we go for a invasive test, that is FNAC, that is fine needle aspiration cytology. And if it is more than 1.5 centimeter, then we go for just follow up of this lesion. Now if the score is 4 to 6 points, then we will call it as moderately suspicious and it is Thyroids 4, and here we go for FNAC if the swelling is more than 1.5 centimeter, more than or equal to 1.5 centimeter, and we'll follow up the patient if the size of swelling is more than 1 centimeter. Lastly, if it is more than 7 or more point, then it is highly suspicious and we have to go for FNAC if it is more than 1 centimeter and follow up if it is more than 0.5 centimeter. So this was about the thyroids and its features of malignancy. Now we'll be seeing some imaging features of this ultrasound. So what we saw as discussed, that microcalcification, these are features of malignancy. Hypoechoic, we can see that the surrounding is darker and the central part is lighter. So this is hypoechoic and it is irregular. So these are the feature of malignancy. So there is high suspicion of malignancy in these type of nodule. And as we go towards the benign features, it will be more cystic, as we can see here, this is cystic, or it will be spongiform as we can see here, or it will be mixed, So as the features decrease from hypoechoic to isoechoic and hyperechoic, the chances of malignancy keep on decreasing. Then we come to the next part of investigation, that is FNAC, that is fine needle aspiration, which is an invasive test where we go and insert a needle in the thyroid swelling, and best is under a ultrasound guidance. So the chances of successful test will be more in case of when we are using a ultrasound guidance USG guided FNAC. So here we can, by ultrasound we can be assured that we are going into the right nodule and we are not having a wrong tissue for diagnosis. So this is the investigation of choice, because that will give us a confirmatory diagnosis regarding the tissue by the tissue architecture and tissue pathology. So this is the investigation of choice. And here we go for a 23 to 30 gauge needle which is inserted in the nodule and aspirated for cells. So here we will have cells. So I just told that we will be seeing architecture. I would like to correct myself that in FNAC we will be only seeing cells and not the tissue architecture. For that we can either go for a biopsy or a FNAB, that is fine needle aspiration biopsy, and that biopsy will give us a tissue architecture. In this we will only have cytology, that is the cells, the morphology of the cells. So here we are using 23 to 30 gauge needle, and these FNAC will help us in determining whether the test given is more towards benign features or is a malignant swelling. Important point that we should note is that in case of follicular lesions, which is a type of thyroid swelling, it is not possible to differentiate between a benign and malignant, that is a adenoma versus a carcinoma, because here we are not able to delineate the invasive features. So here we cannot check the tissue architecture, hence we cannot differentiate between the follicular adenoma and follicular carcinoma, which is the benign and malignant features of follicular neoplasm. So then coming to FNAC of thyroid. So the FNAC of thyroid, it is reported on the basis of Bethesda system, which is a nomenclature for reporting of cells from the FNAC. So it is divided from thyroid from category 1 to category 5. In category 1 it is non-diagnostic. Again we have along with it as 1C, which is non-diagnostic and cystic. In both these 1 and 1C we go for FNAC, we go for a repeat FNAC, and if possible under ultrasound guidance if not done previously. So repeat FNAC under ultrasound guidance. So हम लोग वापस से अगर हमको नॉन डायग्नोस्टिक सिनेरियो मिला है, that is 1 and 1C, then we go for a repeat FNAC under ultrasound guidance. मतलब ठीक से विजुअलाइज करके हम FNAC लेंगे अंडर अल्ट्रासाउंड यानी अल्ट्रासाउंड की मदद से. Then category 2, Bethesda 2, that is non-neoplastic, that is it means it is benign. So here we go for a follow-up, that is clinical and sonographic ultrasound follow-up. तो हम उस पेशेंट को फॉलो करेंगे 6 monthly 1 yearly. Then Bethesda 3, that is it will be a follicular lesion. So here we'll go for a molecular testing of the tissue or hemithyroidectomy depending on the scenario and availability of resources. Then Bethesda 4, it will be suspicious of malignancy. Here we go for a surgery, that is hemi or total thyroidectomy. And Bethesda 5 is malignant, which is almost confirmatory, where we again go for hemi or total thyroidectomy. The next feature is next investigation which we do commonly, not very commonly although, is thyroid scan. And before going to thyroid scan, I would like to discuss that the above three tests which we have discussed, the ultrasound, the thyroid function test, the FNAC. So these three, along with the clinical examination, the history and the physical examination, clinical examination, these four part combined to form quadruple assessment, which is the basic method of assessment for thyroid tissue, which gives us diagnosis most of the times, and it will give us a direction towards our further management. Now coming to thyroid scan. So thyroid scan, what are the indications before going ahead? So thyroid scan, also we can call it as radio iodine scan, thyroid radio iodine scan, because here we are using radioisotopes. So what are the indication? So if there is a residual or recurrent disease after surgery, or the patient is having low TSH with features of hyperthyroidism, to check whether the nodule is hot or cold. Then if we are suspecting or having a suspicion of ectopic or aberrant thyroid, so somewhere the thyroid is not in the anatomical position, if we are suspecting it at other place, then we can go ahead with this thyroid radioisotope iodine scan. So what are the types? So we have two types. So one is technetium 99 scan. So it will give us information about the uptake of the radioisotope, that is technetium 99 in this case. The next or the other one is the iodine scan, that is 123 iodine scan, which will give us about uptake and organification, since we are using iodine, which is the normally commonly used in the thyroid gland. So this will give us about uptake and organification. So depending on this uptake, the nodule or the swelling, it can be a hot nodule. So what do we mean by hot nodule? As we can see in this diagram, so if there is more uptake, okay, that means it is a hyper functioning nodule, or we call it as a hot nodule. So hot nodule or a hyper functioning nodule. So hot nodule or a hyper functioning nodule. So it will have only 4% chances of malignancy, less chances of malignancy, 4 to 5% chance of malignancy, and single hot nodule is also known as solitary nodule of thyroid or solitary toxic nodule. Then multiple hot nodules, it is seen in toxic nodular goiter or toxic multinodular goiter, or also known as Plummer's disease. What is called Plummer's disease. So this was about hot nodule. This is the diagram for hot nodule. We can see here this surrounding is the normal tissue, and here is the hot nodule which is taking more uptake. Then coming to a cold nodule, so here is the diagram, which is a non-functioning nodule. It does not take up iodine and is high chance of cancer. So 5 to 6 times more chance of more risk of cancer than the hot nodule. So 20 to 30% risk of cancer in these. These do not take hot nodule. These do not take up iodine. So this is cold nodule. This is cold nodule. Then lastly, if there is uniform uptake, then it is called warm nodule, or it is called warm nodule. So there will be uniform isouptake. Then in case of Graves' disease, there is diffused increased uptake. So it will be like hot nodule, but it will be involving the complete thyroid gland. So it will be completely extra dark in the whole thyroid region. Whereas in thyroiditis, there will be diffused decreased uptake. So it will be more like the cold nodule, but it will be diffuse, that is involving the whole or complete of the thyroid gland. So just to revise and remember कि हॉट नोड्यूल में अपटेक बढ़ जा रहा है तो वो ज़्यादा डार्क दिख रहा है, कोल्ड नोड्यूल में अपटेक कम हो जा रहा है तो वो कम डार्क दिख रहा है, लाइटर दिख रहा है, ठीक है। लेकिन कोल्ड नोड्यूल में रिस्क ऑफ कैंसर ज़्यादा है 20 to 30%, वेरास हॉट नोड्यूल में कैंसर का रिस्क उतना ज़्यादा नहीं है, 4 to 5% है। देन लास्टली कमिंग टू द इमेजिंग, that is the specialized imaging, which is MRI and CECT. It is useful for retrosternal goiter and for large malignant goiters before going for surgery. CECT will be useful for malignancy, especially it will help us in delineating the extent of spread, especially to the airways, whereas in case of MRI it will be more specifying or more denoting the involvement of the prevertebral fascias and neuronal structures. Lastly, we have PET scan. PET scan that will be useful for metastasis of thyroid malignancy. Now you'll just go through the basic flow chart of management for thyroid swelling or thyroid nodule, which is taken from Sebastian, and it is very helpful in understanding and clinical practice also. So whatever we have studied up till now, the basic part, we'll be trying to apply and understand it together. So when we have a thyroid nodule, we first go for a history and physical examination. That is the first part of the quadruple assessment. Okay. Then after that, we check for a thyroid hormone or thyroid function test, that is TSH, T3 and T4, of which TSH is the most important. If the patient is having low TSH, that means the patient is having hyperthyroidism. So the patient is having hyperthyroidism. So here we go for a radioisotope scan. We go for a radioisotope scan, that is the thyroid scan. So if it is a hot nodule, hyperfunctioning nodule, that is hyperthyroidism with hot nodule, we go for a iodine ablation, that is iodine 131 is used, or we go for a surgery to manage the case. Okay, so in a hot nodule, a hyper functioning nodule, जब ज़्यादा function कर रहा है nodule, hyper functioning कर रहा है, तो we go for a iodine ablation or a surgery. Whereas इसका opposite, अगर वो एक cold nodule है, मतलब उसका वहाँ पे uptake कम है, तो हम क्या करेंगे, उसको अल्ट्रासाउंड से चेक करेंगे. ठीक है, अल्ट्रासाउंड जो हमारा थर्ड क्वाड्रुपल असेसमेंट का थर्ड पॉइंट है. ठीक है, क्वाड्रुपल असेसमेंट का थर्ड पॉइंट है, अल्ट्रासाउंड करेंगे कोल्ड नोड्यूल में. ठीक है, और वापस अगर टीएसएच नॉर्मल है या तो एलिवेटेड है, बढ़ा हुआ है टीएसएच. ठीक है, टीएसएच अगर बढ़ा हुआ है तो वी गो फॉर अगेन अल्ट्रासाउंड, which is the third point in the quadruple assessment. So if in ultrasound we have, that is the TIRADS, which we have discussed, if it is benign or no nodule, there is no need of FNAC. So here it will be TIRADS 1 or 2. Okay, so if it is TIRADS 1 or 2, we don't have to go for FNAC, we just have to follow up. So in case of very low suspicion, that means mild chance of malignancy, we go for FNAC if the size of swelling is more than 2 centimeter. 2 centimeter, or we can also consider 2.5 centimeter as we have discussed. FNAC more than 2.5 centimeter in TIRADS 3. Okay. So 2 to 2.5 centimeter, we go for a FNAC. Then if we are having TIRADS 4, we go for FNAC if it is more than 1.5 centimeter. And in case of TIRADS 5, that is high suspicion, FNAC if it is more than 1 centimeter. So based on FNAC, that is the Bethesda system, that is the fourth part, the FNAC, which gives us the reporting in the form of Bethesda reporting, that is FNAC, fine needle aspiration cytology, that is the fourth part of the quadruple assessment. So ये हमारा 4 पार्ट है जो हम थायराइड नोड्यूल्स को या थायराइड स्वेलिंग को असेस करने में यूज करते हैं. ठीक है. क्लिनिकल फीचर्स, हिस्ट्री, एग्जामिनेशन, thyroid function test, TSH, T3, T4, ultrasound examination which will give us through TIRADS, the findings through TIRADS, and lastly is FNAC which will give us the reporting in the form of Bethesda system, that is the fourth part of the quadruple assessment. So now we'll be seeing in further on Bethesda. If it is non-diagnostic, then we go for a repeat checkup. So we go for a repeat checkup. Whereas in case if it is benign, we go for a follow-up. So this was 1, this is 2. So if it is a follicular lesion, that is follicular neoplasm, or suspicion, SFN stand for suspicious of follicular neoplasm. If there is suspicion of follicular neoplasm, or if there is any atypia of undetermined significance, AUS stands for atypia of undetermined significance, or if it is a follicular lesion of undetermined significance. So in these cases, which is the special scenario, atypia with undetermined significance or follicular lesion with undetermined significance, follicular neoplasm or suspicion of follicular neoplasm. In these cases, we'll go for molecular testing or surgery. So this is specialized scenario. So here we'll either go for molecular testing or surgery. And if we are having more suspicion of malignancy, we'll directly go for surgery. So like this, we'll be managing the thyroid swelling. So this was all about some basics of thyroid disorders and thyroid swelling, and some part of investigation and management of thyroid swelling. How do we go ahead, proceed with management of thyroid swelling and the final management of swelling, whether we go for surgery, whether we go for follow-up, or we go for some other tests. So this was all about the thyroid swelling, the basics of thyroid swelling, and thank you for watching. Please like, share and subscribe, and keep studying, keep growing, and never give up, because great things take time. And see you soon in next video, and keep studying, keep growing. See you.